good afternoon and welcome to this COMPAS webinar on the ethics of COVID vaccination. My name is Eric McGilvray. I'm a professor in the political science department here at Ohio State, and I'm the coordinator of this year's COMPAS series on COVID-19. As many of you know, COMPAS is a program of the Ohio State Center for Ethics and Human Values. COMPAS is an acronym that stands for Conversations on Morality, Politics, and Society, and the mission of the COMPAS program is to promote informed and civil discussion of important and controversial public issues. Obviously, the COVID-19 pandemic is one of the most important and controversial issues facing our nation and the world today. And today's panel is the first in our spring series of COMPAS events that explore the ethical and political dimensions of the pandemic and the response to it. The next COMPAS panel will be 2 weeks from today on Friday, February 19th at this time and also on Zoom. The topic will be COVID in the community, and it will feature David Brown, creative director of the Harmony Project, and William Murdoch, executive director of the Mid-Ohio Regional Planning Commission, with moderation by Wendy Smooth, Associate Dean for Diversity, Equity, and Inclusion in the College of Arts and Sciences here at Ohio State. More details about that panel, including a registration link, and about the whole COMPAS series, including videos of our previous events, are available at cehv.osu.edu/COMPAS. Today's panel, Who's Essential? The Ethics of COVID Vaccination, is moderated by my colleague Courtney Teeley, who directs OSU's graduate program in bioethics, and I'll let her introduce our panelists. So Courtney, take it away.
Great, thank you so much for having me today. It is my pleasure to be here and to introduce our speakers for today. First, Anne Barnhill is core faculty at the Berman Institute of Bioethics at Johns Hopkins University and a research scholar in the Global Food Ethics and Policy Program at the Berman Institute. Dr. Barnhill is a philosopher and bioethicist who works on a range of issues in the ethics of food and agricultural policy, the ethics of public health, and the ethics of influence. During the COVID-19 pandemic, Dr. Barnhill has been working on the ethics of COVID reopening policies, vaccine allocation, and digital contact tracing technologies, and the treatment of essential workers. We're so glad to have you joining us today. Our next panelist is Professor Prasad. Professor Prasad is an assistant professor at the University of Denver Stern College of Law and a Greenwall Foundation faculty scholar in bioethics. His work focuses on health law and applied ethics. Recent publications on COVID-19 include Fair Allocation of Scarce Medical Resources in the Time of COVID-19 in the New England Journal of Medicine, Fairly Prioritizing Groups for Access to COVID-19 Vaccines in JAMA, Setting Priorities Fairly in Response to COVID-19, Identifying Overlapping Consensus and Reasonable Disagreement in the Journal of Law and the Biosciences, A Conceptual Framework for Clear Ethical Discussions about COVID-19 Response in AJAB, and Allocating Medicine Fairly in an Unfair Pandemic in the University of Illinois Law Review. Professor Prasad, welcome. We're glad to have you as well. So our format for today, just quickly before I hand it over, each of our panelists is going to give a brief presentation, and we're going to follow this with an opportunity for discussion and conversations together. And as part of that, we welcome you as participants to please use the Q&A feature to submit your questions. You can submit them throughout the talk, and we will get to as many as we can today in our conversation. So we invite you to participate in our conversation today. Thank you, and with that, I'm going to hand it over to Dr. Barnhill.
Great, thank you, Courtney. I'm gonna share my screen. So let me do that. Okay, good. Okay, great. I'm gonna kick things off for us. Oh, and thank you, Courtney, for that introduction, and thank you for the opportunity to be here. This is a neat series on COVID issues. Okay, so I'm gonna kick things off for us, and I'm gonna do some broad ethics framing of the issue, and then at the end of my comments, I'll pose some specific or identify some specific questions that I think are interesting questions about COVID vaccine allocation that are being discussed. Okay, the issue before us is this. There isn't enough COVID vaccine now to offer vaccine to all who want it, so who should be offered COVID vaccine first? And this is a question at the country level, like which groups of people within a particular country should be offered COVID vaccine first. It's also a question at the international level. So how should scarce COVID vaccine be allocated between countries? And I'm just going to talk about COVID vaccine allocation in the United States, but I just wanted to stress that these international allocation questions are also incredibly important. So I was a part of a working group at Johns Hopkins that looked at this issue, led by Dr. Eric Toner, and we created an ethical framework for COVID vaccine allocation in the United States, and we wrote this report. So I just want to give a shout out to my co-authors. And what we did in our report, one of the things we did in this report, and what I'm going to do now, is to kind of go back to the basics, the ethical basics. So start with kind of broad fundamental ethical values, and then kind of show how we can work from those towards an allocation scheme for COVID-19 vaccine. So during the COVID-19 pandemic, vaccine is not the only scarce medical resource. So other resources have been scarce, in certain places at certain times, or there's been a kind of looming threat of their scarcity. So for example, beds in intensive care units, ventilators, tests, personal protective equipment. And so when there isn't enough of a scarce medical resource to go around, who should get it? So that's an ethical issue that bioethicists have written about quite a lot. And my co-panelist, Govind Prasad, actually co-authored a great paper about the allocation of scarce medical resources, giving a framework, a sort of general framework for the allocation of scarce medical resources. And I'm just going to give you a kind of simple way to think about the allocation of scarce medical resources. Like, how do we go about working through that in a particular case? All right, so according to this simple way of thinking about the ethics of allocating scarce medical resources, there are these two broad ethical values that should guide the allocation of scarce medical resources. And one of these broad ethical values is, the value of maximizing the good or promoting the common good. And the second broad ethical value is that of treating people fairly and promoting equity. So when we have a scarce and precious medical resource that can prevent illness and save lives, we want to use it in a way that does good, of course, that provides benefit, as much benefit as possible. But we also want to make sure that we are treating people fairly and that we are paying attention to inequity. So like, we're treating people fairly as individuals, and we are paying attention to inequities across individuals, but also across social groups. So when deciding how to use the scarce, precious medical resource, we really need to balance these two broad ethical values. But first, we need to figure out what these two ethical values demand when it comes to allocating the scarce resource in question in the context in question. So to determine the allocation of a specific scarce resource in a particular context, like allocation of COVID-19 vaccine in the United States at this point in the pandemic, so to determine allocation of a specific scarce resource in this particular context, first, we figure out what maximizing or promoting the common good requires in that context. So we identify what are more specific goals or more specific ethical principles that achieve maximizing the good or promoting the common good, or advance maximizing the common good or promoting the common good. And the next we figure out what are the kinds of fairness and equity that are relevant in the context in question. And we do the same thing here. We're identifying more specific ethical principles or goals that advance fairness and equity in that context, advance relevant forms of fairness and equity in that context. And then next, we try and figure out which groups of people should get priority access to the scarce resource in order to advance these various ethical goals. And then the last step is, balance these various ethical goals if they are in tension. So you might find out prioritizing group A saves the most lives, prioritizing group B addresses the most egregious social inequities, and then you've got a tension between these two worthy ethical goals, and you need to figure out how to balance them. Okay, so let's do that. Let's go through this process, at least partway, for the case at issue. So when we think about allocation of COVID vaccine in the United States, what does the broad ethical value of maximizing the good require? Well, one way that this has been thought about in allocation is that, maximizing the good, or an allocation of a scarce medical resource, that maximizing the good is about maximizing health benefits. So people have proposed specific ethical goals like save the most lives, or save the most years of life. So these are goals or principles. They tell you to allocate the vaccine in whatever way saves the most lives, allocate the vaccine in whatever way saves the most life years. And both of these specific goals are about maximizing health benefits, but maximizing health benefits in different ways. And when we think about allocating COVID vaccine, of course, a primary goal is to save lives, to prevent people from dying of COVID-related illness, and to prevent people from getting COVID-related illness. Okay, so when we're thinking about this broad value of maximizing the good or promoting the common good, I think promoting public health, protecting public health is a central goal. And then more specifically, more specific goals are preventing, COVID-19 related illness and death, but also protecting the health system, which is necessary in order to protect public health. But the COVID-19 pandemic has also had an enormous economic and social toll, not just a public health toll. So when we think about this broad value of maximizing the good or promoting the common good in the context of the COVID-19 pandemic, it's not just about promoting public health or saving lives. It's also about, promoting economic and social well-being. And one thing we've seen is that, during the pandemic, some workforces have been depleted. So I live in Baltimore, and in Baltimore, our recycling wasn't picked up for months because the workforce of workers, who pick up recycling got depleted. So when we think about, promoting the common good, promoting economic and social well-being, we need to think about protecting a range of essential services, and that requires us to protect those essential workforces. Another thing that's happened during the COVID-19 pandemic in the United States is that many children are home from school and daycare, which is a tremendous burden on families and very harmful to some children, and a drain on the economy when parents can't work. So when we think about promoting the common good during the pandemic, another specific goal I'd add here is, this last one, enable children to return to school and childcare settings. Okay, and now moving along to our second broad ethical value, treat people fairly and promote equity. So here we want to ask, what are the specific forms of fairness or specific forms of equity that are relevant? And one thing we've seen during the COVID-19 pandemic, is really significant racial disparities in COVID-related infection, hospitalization, and death. So we've seen, higher rates of COVID-related death among Black and Latino people in the United States as compared to white people. And these disparities have many causes. And, in my view, they're rooted in forms of background disadvantage and marginalization that are themselves inequitable. So these racial disparities in COVID burden are an injustice and inequity. And thus we have equity-based, justice-based reasons to address them. So a specific goal here, is to address background and emerging inequities between groups. Another kind of fairness or equity that is very relevant in the COVID-19 pandemic is reciprocity. So showing reciprocity to people who've taken on risk to provide essential services during the COVID-19. So for example, frontline healthcare workers, or people who participated in vaccine trials, or other forms of essential workers who undertook risk to their own health in order to keep the ship afloat. And so the idea here with reciprocity is that, we owe a debt to them. Like we owe a debt to people who have taken on the risk. And thus it's only fair to prioritize them for vaccine and thereby reduce their risk going forward. Okay, so I think there are additional forms of equity or fairness that are relevant, but just for the sake of time, I won't talk about them. Okay, so, we started with these two broad ethical values, and now we have a list of more specific ethical goals, like save the most lives, or enable children to return to school, or reduce higher rates of, COVID health burden among Black and Latino people, or show reciprocity. All right, so our next step is to take our goals and then identify groups whose prioritization would advance those goals. So for example, to enable children to return to school and childcare settings, prioritize K through 12 teachers and other school workers and daycare workers, for example. Okay, so we would do this for our various important goals. And then we would have a number of potential groups who could be prioritized for vaccination and whose prioritization would advance these important goals. And as it turns out, for some of these groups, prioritizing them advances multiple goals. So for example, prioritizing frontline healthcare and certain other essential workers, protects the health system and protects other essential services, and it shows them reciprocity. And some of these frontline workers have a higher risk of COVID infection and a higher risk of transmitting COVID to others. So it also advances the goal of reducing COVID infection and death. And when we find that there are some groups whose prioritization advances multiple goals, that's great. So that's always nice to find. But in some cases, there may be trade-offs. Prioritizing one group advances one important policy goal, prioritizing another group advances another. And then that's where you really have to decide, how to balance these different goals. And you have to decide which goal is more important. And that is a matter of, then thinking about the underlying ethical principles and the underlying values. So is saving the most lives more important here than showing reciprocity, or than, getting kids back in school as soon as possible? All right, so that in a simplified form is the kind of process of starting with very basic ethical values and then getting to more specific priority groups. And now quickly, I just want to show you what the US federal government did. So the Centers for Disease Control and Prevention, they have this committee which makes recommendations about vaccines in general, and they did this about COVID-19 vaccines. I just pulled this off of their website today. So they list their websites and then they introduce them by saying, these recommendations were made with these goals in mind: decrease death and serious disease as much as possible, preserve functioning of society, reduce the extra burden COVID-19 is having on people already facing disparities. So those should sound familiar by now. These kind of broad, broad consensus goals that we want to, protect public health, reduce the COVID health burden, preserve, economic and social well-being or functioning of society, and also address disparities. Okay, so here is the prioritization scheme that the CDC committee recommended. So phase 1A was healthcare personnel and residents of long-term care facilities. And it's because residents of long-term care facilities accounted for so much of the COVID-related mortality. Last I heard it was like 40%. And then phase 1B is some frontline essential workers, people 75 and above because they're at high risk of hospitalization, illness, and death. Phase 1C is like the next age group, people aged 65 to 74, because they're also at elevated risk of severe COVID illness. And then also in this phase 1C, people, younger people who have underlying medical conditions that increase their risk, and another group of essential workers. Okay, so that's what the federal government recommended. And states are broadly following that. That's my impression, though there is some notable variation from state to state. So for example, there's some variation in when different groups of people who are at higher risk of COVID, severe COVID illness, are eligible. So states varied in when people aged 65 to 74 became eligible. States have varied in which people under age 65 are eligible. And there are other forms of variation between states as well. And all right, I was going to give you an example, but I won't for the sake of time. Just this example of how New Jersey now, there's this broad group of people aged 16 to 64 who are eligible for vaccine now in New Jersey. That's where I used to live. Whereas in Maryland, it's a much smaller group of people aged 16 to 64 are eligible. New Jersey is opening up vaccine to a really significant percentage of the adult population who have underlying health conditions like smoking or obesity that increase their risk. Maryland is not doing that. A very significant difference in their allocation schemes. Okay, all right, so another, I think, interesting question, important question to look at is within these broad allocation groups. So like if a state now says everyone age 65 and above is eligible, within that broad group, who is getting vaccine first? Because there isn't enough vaccine available, to vaccinate everyone age 65 and above. And one thing that, it seems to be happening in some states is first come, first served, like whoever logs on when more vaccine appointments open up and get an appointment is going to get vaccinated. And I think that raises really significant equity issues. So maybe we could talk about that. And I just wonder, what are the best ways? A kind of like very immediate question now is, what are the best ways to like further prioritize people within these broad allocation groups? Okay, all right. I think I will just stop there for the sake of time and turn it over to Govind.
All right. Hi, everyone. I'm Govind Prasad from the University of Denver. I'll go ahead and share my screen as well to go through my presentation. It's great to already have Anne's presentation, be able to build on that. All right. So I'm going to start out with something that I think Anne already covered, which is, what are the harms that vaccines prevent? And I have 4 listed here. I want to flag the first one because I think it's important to draw a distinction that I think has been underdrawn, which is that people say, vaccines, allocate them to save more lives, prevent deaths. As it turns out, we actually can't prevent deaths. Everyone is going to die at some point. Some people have used this as an excuse for saying, well, we shouldn't do anything about the pandemic because everyone will die at some point. That's not right either. But when we're talking about preventing deaths, what we're really talking about is postponing deaths, making it the case that someone who would have been at high risk of dying now from COVID-19 instead dies later than they would have otherwise died. Another value, which I think, again, really ends up being sort of coming together with preventing deaths, is preventing loss of future life. Then yet another value, which, again, I think we've focused a lot on preventing deaths because I think it's often a good proxy for loss of future life, is preventing outcomes like being hospitalized for COVID-19, put on a ventilator, things like that, getting really sick. People who end up being hospitalized, it's often really bad and burdensome for them, even if they don't end up dying, so that matters as well. And then last, which Anne also talked about, is indirectly, vaccines can help to prevent a lot of different societal harms. Poverty, because you don't feel safe going to work because you might get COVID or give COVID to your mom that you're taking care of, or your customers won't come because they're worried they might get disease. Anne talked about the example of lost educational opportunity because of schools, childcare being closed. Oppression of various kinds, so people being unable to travel to where they need to go, people being, there's been a huge problem of people leaving the workforce, disproportionately women, because of lack of childcare due to COVID-19. So you have both, and the other point I would make here is that in the end, these are interconnected. So if you have economic downturn now, that's going to translate sort of predictably into more deaths, more loss of life later on. At the same time, if you have deaths right now, it's not just bad in itself, it's bad because those deaths harm people who stay alive. So there's an interconnection between, that is, preventing poverty isn't just preventing poverty. You could also think of it as preventing future deaths. Preventing deaths isn't just preventing deaths, it's also preventing harms that flow out from those. In thinking about the ways that vaccines prevent harm, it's also worth thinking about the different pathways by which COVID-19 in the pandemic can cause harm. So one of the sort of major pathways is going to be people being exposed to being infected initially. And some of the factors that make people vulnerable to infection generally have to do with being exposed to other people who might have COVID-19. So exposure at work, exposure in housing. So if you're in crowded housing, if you're in congregate housing, that's another source of exposure. Exposure through caregiving responsibilities, exposure through geography, being in a geographic area neighborhood where COVID-19 spread is higher. Another set of pathways to harm has to do with poor outcomes if you get COVID-19. So if you are not immune to COVID-19 because if you've been vaccinated or you have recent prior infection, that's an obvious way that you're more vulnerable to bad outcomes once you're exposed. Other factors that look like they correlate with poor outcomes if you're infected would be older age, certain specific medical conditions like diabetes or Down syndrome. I think poverty probably falls into this category because it correlates with less good access to medical care that could be helpful to you if you're infected. And then last is going to be sort of indirect harms to other people if you get infected. So the one that people think about first might be the spread of COVID-19 in the community. But another important one is going to be loss of assistance that's needed by others. So for healthcare workers, if you have doctors that are quarantined because they're infected or who are sick or who are hospitalized or dead, they can't provide either COVID-19 or other forms of medical care to people. Staffing shortages end up being an issue. Similarly for loss of essential caregivers or essential workers in other areas. And these overlap. So I find this example really interesting. This is from a piece that a Bloomberg columnist, Noah Smith, wrote on his Substack just after the meeting about which groups should be prioritized federally. And what he argued, and I think this is broadly pretty plausible, is to save the most lives, vaccinate people who are have both high exposure, high risk of poor outcomes if infected. And there are a variety of factors that sort of pick out each of those. He said, looking at all the disparities in exposure and infection, vaccinate people who are old, poor, Black, diabetic grandpas who are working in meatpacking plants. So vaccinate people who are exposed through work, through racism, to greater risk of infection, who are exposed to poor outcomes from age, from poverty, from illness. Look at the overlaps between these different pathways and who's at kind of the intersection of these different pathways to harm. There's a few different mistakes about benefit that have been pretty common during thinking about pandemic response. So one big one I think has been a sort of short-term focus. People have said, vaccinating group X will save the most lives. I think we should always try to figure out over what time scale do you mean save the most lives? And it might be that it's more direct or immediate that lives are saved by vaccinating one group, but that if you look over a 5-year time scale and at indirect effects, or over a 50-year time scale, you actually get a different answer. Similarly for indirect effects, people sometimes say, well, don't vaccinate this group. That group is really unlikely to die of COVID-19 if they get it. But it's also important to ask, how will their not being vaccinated, how will their getting COVID affect others? So, for instance, if you have staff who work with people who are very vulnerable, even if they won't die of COVID if they get it, their getting COVID could end up affecting others either through spread or loss of essential assistance. So it's really important to remember that what I think ethicists call the rule of rescue, saving the most short-term direct lives, is not the same thing as either maximizing sort of the social benefits of a vaccine or allocating the vaccine in the way that's most equitable. I think that often we've, for sort of political and other understandable reasons, focused on a kind of large-scale rule of rescue, as opposed to thinking about either benefit or equity in a more systematic and less short-term way. So now I want to turn to equity, which is, I think, a term that people use a lot and has a lot of different dimensions. And some of those dimensions, I think, are going to be better served by vaccine prioritization than others. So one dimension of equity that I find ethically compelling and I think is well served in vaccine prioritization is addressing health disparities, which Anne also talked about. And I think it's most compelling when we think about health disparities as correlations between the risk of getting really sick or dying sort of in the COVID-19 pandemic and other sorts of social categories or identities that subject people to other sorts of harm or risk, like risks of being subject to racism or ableism or sexism. So for instance, I think addressing disparate deaths in the Black or Native American communities from COVID-19 is a compelling basis as well for prioritization. And as I'll explain later, it also ends up generally correlating with benefit. This is an area where equity and benefit don't necessarily pull against each other. Similarly, for disparities in terms of people with, say, Down syndrome being much more likely to die of COVID-19. I think it's less compelling if you thought about health disparities in, I think, a way that's not the right way, which is just as disparities between who's healthy and who's unhealthy. Some people are always going to end up being healthier or less healthy in a pandemic. I think it makes more sense to think about it in terms of correlations. Similarly, I think vaccines can also sometimes be a helpful way of assessing people who are worse off overall, not just say with respect to health, but with respect to other aspects of well-being like economic status or other types of oppression. Although it's also important to think about whether there are other levers that we might have at our disposal in policy that might be more effective than vaccine allocation at helping people who are worst off overall. Then there are some others that I think are pose greater challenges. So a couple that I think I have doubts about how important they should be relative to prioritizing the worst off or addressing disparities, but that I also think might be better compensated through other means than vaccines are things like compensating for historical injustice, reciprocity for past social contributions. And the thought here is that even if we do think that these values are important values, there are other means at our disposal to address these issues. People who made past social contributions may not be at high risk of getting, spreading, or getting really sick from COVID-19. The same might be true for people who have experienced historical injustices. And it might be that for that reason, vaccines are going to have much less benefit for them than they would have for somebody else. Whereas a kind of all-purpose good, like say money, might be a more effective way of addressing those backward-looking issues. So that's what we argue for in a paper in JAMA, is that reciprocity is in general not a sensible way of allocating vaccines because we have other means at our disposal, and vaccines are poorly targeted because of the fact that their benefit for some is going to be so much less than their benefit for others. It'll be better to address reciprocity via all-purpose goods. Let me go to the next slide. So coming back to this issue about saving lives, is saving lives the only thing that matters? People sometimes talk as if saving lives, which I've tried to argue before, really means sort of postponing deaths, is the only thing that matters. I think it matters a lot, but I think that actually when you look at examples, people really think other values matter as well. So a few different examples. Say we reflect on a situation where imagine that the risk curve for COVID-19 were the opposite of what it actually is, so that young kids and teenagers were at hugely greater risk instead of people later in life. If you just thought that saving lives were all that matters, you wouldn't care when death happened to people. But I think a lot of folks are going to think actually COVID-19 is awful now. But I think even a lot of older people, I think my mom, for instance, who's in her 70s, definitely thinks this pandemic is awful. But I think she would be a lot more upset if her grandkids were at the same risk as she is. Similarly, I think if you just cared about saving more lives, you might use certain categories that we might think are unjust or objectionable for other reasons. So for instance, it turns out scientifically male sex correlates with greater probability of death. If you just cared about saving more lives, you would actually vaccinate men first within a given age bracket. As somebody who identifies as a man, I would say there are reasons to be troubled about this, and the reasons to be troubled suggest that saving lives isn't the only value. Some sort of value about not considering certain characteristics might matter too. And then last, national borders. If you just cared about saving more lives, you might provide vaccines across borders before you provided vaccines within your country. I think a lot of people might push back against this, and there'd be really heated debate if we said, let's send vaccines to vulnerable older people outside the US first. So I think this all just shows that people care about values other than saving lives, even though for vaccines, saving lives often aligns with equity considerations. think a couple of issues that have come up in the ACIP proposal are that I think that benefit and equity have been placed into conflict when really they shouldn't be, often in conflict. So the way that ACIP made its recommendations, they said, prioritize people who are older, and then also prioritize people who are essential workers regardless of age. If you just use age though, it tends to, say you use an age cutoff like 65 or 75, you end up disparately excluding minority populations, poor people, less healthy people. Those folks tend to die younger in general and tend to die younger from COVID. So one study in Rhode Island recently suggested your risk at 55 in the Black community is the same as your risk at 65 otherwise. If you just do occupation alone, that's really suboptimal in terms of benefit, because if you're under 30, even if you're very exposed, you're not likely to die or be hospitalized. So the ACIP categories, the way I put it here is I think they go wrong by prioritizing well-off, really old people like Rupert Murdoch, and then people who are very exposed but not very vulnerable, like teenage grocery store baggers, over people who have overlapping risks but don't fall within either the age-only or occupationally only categories. So somebody who's a diabetic 60-year-old primary caregiver doesn't get any priority, and that seems troubling both from a benefit and equity standpoint. Many states have ended up going with a more age-based approach, thrown out the frontline workers, because they've worried about lobbying, they've worried that people will pretend to be an essential worker, they perceive that using age is simpler. I think it would be better to try to work harder to align benefit with equity, focus on people who are both at higher risk of exposure and higher risk of death once they're exposed. That's what we did for long-term care residents, and I think that was a sensible prioritization. There are other things that might build on this. So look at high-risk conditions that correlate with disadvantage. We know that high-risk conditions are more common in communities that are disadvantaged, so you could end up aligning equity with benefit. There are implementation challenges here, which is that people often think, well, you need to verify if you do this, and that you do have a correlation between undiagnosed high-risk conditions and disadvantage. You also have overlapping risk-based priorities you might use. So West Virginia is prioritizing people who are teachers who are also over 50. The state of Washington is prioritizing multi-generational households. And a lot of different localities are using what I've called place-based approaches. So using indices of disadvantage or zip code to try to prioritize people who are at higher risk in these big categories like over 65. My last slide is just about a common, I think, misconception that I just saw today and was very grumpy about in the New York Times, which is this idea that if you prioritize people who are the most vulnerable, it will slow things down too much. And so you should just get vaccines in arms and forget about prioritizing vulnerable people. I think this is a mistake, and I've started to become more and more worried that it's a mistake that's motivated by sort of odious preferences to just get vaccines to better off people faster, which might be unfair, but that's something I started worrying about more. I think verification and narrowing eligibility will slow things down, but just prioritizing the most vulnerable, say among everybody over 65, is not going to slow things down because you already have many more people eligible than there are vaccines available. So I'd say do proactive outreach to high priority communities. Consider options that some states have used, like having earlier signups, open your sign up earlier, a day or an hour earlier for people who are in high priority groups, or have the kind of the equivalent of a frequent flyer line where they get to go ahead of people in the general over 65 population. To the extent you're worried about people sort of jumping the line by preventing to be in a risk group they're not, don't try to do it by making people fill out 40-page forms or finding doctors who vaccinate somebody out of order. Instead, have penalties, targeted penalties, for the things that are actually bad. Stuff like people selling vaccines or giving vaccines to their friends and family instead. And then an interesting option I'd love to talk more, think more about is for people who already recently had COVID-19, it may make sense to recommend, as the CDC right now does, delaying vaccination for 90 days until people who are at higher risk because they haven't been exposed yet, haven't been infected yet, get vaccinated. And I know that some folks are doing studies looking at whether those folks might be able to receive only one dose as a booster instead of having to go through the full 2-dose process. So it's worth thinking about ways that we might be able to use the limited supply more effectively. But in the end, I agree that vaccines in the trash because of some sort of delay are the worst outcome. I just think that there are ways to prioritize that prevent vaccines in the trash. We have a blog coming out in Health Affairs about this, that keep vaccines out of the trash while also prioritizing vulnerable communities. So that's it for me, and I look forward to questions.
Great, thank you both so much. Those were really just thought-provoking presentations, so appreciate that very much. Before we dive into questions, I want to give each of you the opportunity just to respond or comment on the presentation by your fellow panelists. So Dr. Barnhill, I will give you the opportunity to respond first.
Yeah, thanks, Courtney. And thanks, Govind. Yeah, so I have a thought, or I think, I think we are thinking along the same lines about one issue. So I just wanted to note that and maybe think about it a little bit together. So yeah, I have also been dismayed about this kind of sentiment that we just need to get vaccines in arms as quickly as possible, right? And I think, of course, there's trade-offs between, if we're just thinking about saving the most lives, put equity aside for the moment, there's trade-offs between, getting vaccines into arms as quickly as possible, and going slower and targeting high-risk people more precisely. Or we've got these two different options, right? We could just try and get vaccines into arms as quickly as possible, or go slower and target high-risk people more precisely. And of course, if we go sufficiently slowly, then that's not going to save the most lives overall, right? Because we want to vaccinate a bunch of people. We want to reduce the amount of virus that is spreading in the population and mutating and potentially becoming more dangerous. So a certain amount of speed is necessary. Okay, so this position that we should just get vaccine into arms as quickly as possible can't be correct. There's some trade-off, or there's some optimal balance. There's some level of slowing down and more precisely targeting high-risk people that is optimal. Okay. And so then I was interested in what you said, that prioritization among the eligible doesn't slow things down. So narrowing eligibility does, but prioritization among the eligible doesn't slow things down. And I guess I just wanted to talk through that a little bit more, right? And so you had this idea of a frequent flyer line. And so the idea would be, right, like everyone over 65 is eligible to get vaccinated, but you give some kind of priority to the people over 65 who also have an underlying health condition or are also essential workers. Yeah, okay. So I just want to talk about that more and why you're confident that that doesn't slow things down, or is your thought, let's just figure out how to do it in a way that doesn't slow things down. And it may not be perfect, right? Like there may be groups of highly vulnerable people who even aren't going to make it into the frequent flyer line, right? Like the meat processing workers who don't have health insurance and don't have a primary healthcare provider, and are low income, may be really hard to reach and may not make it to the frequent flyer mile. So we might just have to not have a system that scoops up the most disadvantaged, but still have a system that prioritizes the more disadvantaged. All right, I'll stop there. And
sure. Should I answer that? Yes, so I think it concedes way too much. I don't think it's accurate to concede the idea that it slows things down in any way. I don't buy the trade-off line about it will slow things down to prioritize people who are vulnerable, as against the status quo. And here's why I don't think it will. If you have a first come, first served system, say you have 10 appointments in the day, first come, first served means they'll go to the people who can click on the link the fastest. If you say, and say the appointments are in a week, if you instead say, we will have the appointments open for a day to people who are in some priority group, and then you open them up, there is no way in which that will slow things down at all compared to first come, first served. It will never be slower. Now, it may miss some people who can't show that they're in the priority group, so it's imperfect, but it's still a lot better than first come, first served, which doesn't even try to prioritize people who are vulnerable. I think that overall the approach of, or the other answer would be, I think, proactively call the people who are in, Camden, who are in over 75 for the spots on Monday. And then if they don't take those spots, then open them up on Tuesday for everybody else. And the spots are next Tuesday. It doesn't slow things down at all. I think people have created a false idea that there's a trade-off between speed and prioritization there.
Can I just respond to that? So some people just aren't going to make it into the frequent flyer line at all. So, if your system for having people register for vaccine appointments is that they either wait on the phone for a long time or, they do it online, there's going to be some people who aren't going to be able to do either because they're working or because they have caretaking responsibilities. And even if the appointments are available to them a day earlier, that doesn't do them any good because just realistically, they're not feasibly going to be able to get online in time or get online at all, or even know that they're eligible. So I guess, so it seems to me that prioritizing the most vulnerable in a way that doesn't slow things down at all is possible, but it may leave out the most vulnerable. And so it may be an advantage on saving the most lives and on equity as compared to the first come, first served system, which is really bad. But there's still going to be significant inequities, or it's still going to be significant failures to target the most vulnerable, right?
Yeah, I'm saying it's preferable and that the current system is a disaster. I'm not saying it's perfectly optimal, and I worry that searching for perfect optimality in prioritization tends to lead people to say, let's just throw it out because not everybody will be able to prove they're the most vulnerable. So let's just use first come, first served or a lottery instead. And I just think in the end, that's going to be more people are going to die, and it's going to be more, as it is now with first come, first served, more poor people, minorities, other folks who are dying. So that's my thought on.
Yeah.
Yeah, thank you each for this. And as I was listening to your presentations today, I couldn't help but think about just even once you have these groups open up, that way in which they are signing up. So phone calls, online signups were mentioned, and it does seem like there is particular challenges there for access. Particularly, I think of older individuals who maybe aren't as comfortable with the online signups or using that for accessing their medical charts, or individuals who maybe don't have access to computers or who would use libraries as their primary source of internet access, but maybe the public libraries aren't open now, except for drop off and pickup. That's how it is here. So I think that, waiting for perfect is definitely a challenge that you both recognize. So it's doing the best in which we can in circumstances that are certainly not ideal. And I think that's a theme that I've been hearing. So actually, I wanted to follow up though with a question. Govind, you mentioned this idea of kind of outreach campaigns to vulnerable communities. Besides like internet outreach and actually kind of targeting, what do you think would be some practical ways we could do that?
I wouldn't actually think about internet outreach, particularly for over 65. I think calling people, going door to door would be the way of doing that. I think you've seen some health systems, some localities actually do that. I would also, in some ways, I'm not the best person to answer this. I would say, ask people who are community leaders in these communities, in your community of folks who are eligible right now, how do they find out about stuff? And then get your person there to talk about that. But I think it's important to be active rather than passive. I think right now our system has been very passive. It's been, hey, we'll throw up a website and see who signs up.
Great, thank Thank you. We have quite a few questions coming in from our participants today, and we have about 10 minutes left. So I want to make sure we have time to address some of these. So I am going to jump right in if you guys are ready for that. Our first question I want to address is from Dana, and she asked, what do you think about states changing course mid-vaccine allocation? Some nimbleness seems important to maximize benefit on the ground, but changing course and upending people's reasonable expectations seems unjust.
I would just assume that revoking eligibility to people who you've given eligibility to would be a really bad idea. It would just create confusion and undermine confidence in the vaccine allocation program. That's not really based upon any particular specific relevant data, though. That's what I would assume. I mean, I think a kind of nimbleness that it would be great for states to have, though I don't know if they have the resources to do this, is to do this kind of like targeted, like Govind was talking about, kind of like targeted outreach. And so to kind of on top of their prioritization scheme, right? So be nimble, not in terms of like revoking eligibility from anyone, but actively reaching out to taking the vaccine to subgroups among the eligible, among those who are already eligible seems great. So kind of take the vaccine to the meat processing workers, or take the vaccine to the farm workers who are significantly disenfranchised in many ways. That kind of nimbleness seems great. Or be nimble in response to a kind of hotspot, right? Yeah, that's what I would say about nimbleness.
Thank you. Professor Prasad, anything you would like to add to that?
I did another one. I tried to answer that in the typed answers, but I think this is a well-known thing, and Anna and I discussing. I don't care as much about sort of quote reasonable expectations. I don't think people have a reasonable expectation that policies around COVID-19 are going to stay the same. They might have an expectation. I don't think it's reasonable. I do think policymakers should have been more clear with people that this is a dynamic process. Things could change. What if it turns out the variants are more harmful to people who are younger, for instance? So I don't think that people should have expectations that just because they're eligible now, they'll stay eligible. But I think policymakers should be clearer about that.
Yeah, transparency, just transparency really being key there. Next question is, how can we construct targeted penalties so that they aren't just a price that could easily be paid by the wealthy? So something punishable by a fine is legal for the ultra wealthy, but imprisonment is contrary to preventing the spread of COVID. So I think getting at those targeted penalties versus the kind of checking for verification that you raised, Professor Prasad, in your presentation.
Sure. I mean, I think this is a challenging problem in some ways. I would say focus on the institutional actors who are distributing the vaccine. Like, if you're a doctor and you started like giving out transplantable kidneys to your donors, your hospital would stop being able to give out organ donations, and you might lose your medical license. And I guess I think the same sort of thing would be justified for if you start giving out COVID vaccines to like high payers or skipping your mom ahead of other people. So I think it makes sense to focus on the institutional actor. And I also think people should see this not just in a way as a matter about financial penalties, but honestly, a matter of sort of professional ethics, in the same way that you don't, rat out your criminal defense client to get money, or you don't give kidneys to people who pay you. You shouldn't give vaccines for money. That is really different, I think, from if you were going out of order with vaccines that are getting wasted.
Thank you. And Dr. Barnhill, anything you'd like to add a comment?
No.
Okay. We have a couple of questions that are focused on reciprocity. So I'd like to move to those next. Justin comments that there seems to be some disagreement in your approach to reciprocity, or maybe it's just at least a different focus on different cases. And says it's one thing to say reciprocity in light of past injustices is a bad consideration for vaccine distribution. It's another to deny that to those who've risked their lives to provide vital services during this pandemic, have a claim on grounds of fairness. I also wonder about negative reciprocity, reducing vaccine access on grounds of ignoring public health mandates. So just wanted to know if you could comment on that.
Yeah. So the kind of reciprocity that I think is a good idea is to reduce people's ongoing risk, right? Like essential workers, the risk hasn't ended, right? They are they experience ongoing risk. And so it's not that we are compensating them for past risk, it's that we are reducing their ongoing risk. So I'm curious if, what Govind thinks about that. And yeah, and then the negative reciprocity, again, I think kind of ethics aside, that seems imprudent, like something that would undermine public confidence in the vaccine effort in a way that may be counterproductive to the end of protecting public health.
Yeah, to the question as typed, I can see that people who have risked their lives to provide vital services during the pandemic have a claim to something on grounds of fairness. But I don't think it makes sense to think of that as a claim to vaccines that are going to potentially avert much more harm if they go to somebody else than if they go to somebody who risked their lives to provide vital services. Like if I risk my lives to provide vital services, I got COVID, 30 days ago, I recovered. It does not make sense. I think that the loss to benefit and to other dimensions of equity is so great that it doesn't make sense. And I think this is honestly generally true for reciprocity here. I think we have so many better avenues to recognize reciprocity. Open your wallets, don't give vaccines to people for reciprocity.
Great, thank you. Building on the reciprocity questions, and part of this you got us, I'm going to just ask the second half of the question. This is from William. Just asking, in retrospect, do we think that the heavy weight on reciprocity, so I think referring to like healthcare workers in phase 1A, did it make sense? And if you could reconstruct going back or even going forward how we were prioritizing, would you do it that way again or do it that way moving forward?
Yeah, I have a thought about this. I've had some conversations about this. So, healthcare workers now have, protocols in place, right? Or healthcare workers may now actually not face significant risk of COVID infection, even when they are having contact with COVID workers because of the personal protective equipment they have and protocols that they have. And so, so I think this is the possibility that, if I could go back and do it over again, maybe we would sort of hammer away at that more and see like, what kind of evidence do we have of the actual level of risk that different groups of essential workers face? And if healthcare workers, in fact, have lower risk, because they have better protections, despite the fact that they are dealing directly with COVID patients, then we should take that into account on the one hand. On the other hand, I mean, healthcare workers, we really have to worry about burnout and not just COVID risk. And like for them to have to vigilantly follow these protocols minute to minute, month after month is just hard on them. And so there may be, there may be, vaccinating healthcare workers may serve to maintain the healthcare response in other ways aside from preventing healthcare workers from getting sick from COVID. I guess is the way I would unpack that.
Great, thank you so much. We have 1 minute left, so I'm going to try to get one more question in if hopefully we can. It's kind of a big question though, so we might stick another 30 seconds or so. It says, Dr. Barnhill mentioned the global context of this conversation at the beginning of her talk. In the global context, have either of you seen processes of prioritization or distribution that you think have worked better or worse in countries outside of the United States? So we're looking to others for examples, I guess. What can we learn?
Yeah, I don't really have any good examples. at hand?
Globally, I think some countries that have gone pretty quickly, I think it's hard to know at this point what has worked the best. I think Israel has the example of a country that's gone very quickly, has used primarily age bands, but has also been very flexible about who gets vaccines if they're running out. But it's a tiny country geographically. I'm not sure it's the best guide. I do think, here's my thought about first come, first serve, this is my answer. I think in the US, we tend to valorize the idea that people who are deserving, who have worked hard in some way, should get priority for stuff. And so first come, first served, or even these lines that are outdoors where you camp overnight, which seems to me like unsafe, disgusting, designed to harm equity. I also see why in some ways it might distinctively appeal to a dimension of the American psyche, because the idea is that it creates a kind of work-based, effort-based allocation of how you get the vaccine. You get the vaccine by putting in the hard yards of, getting your chair and camping out overnight. And if you didn't have the wherewithal to do that, maybe that means you shouldn't get the vaccine. And I find that really sort of inefficient and inequitable. But I could see why maybe that's more compelling to people in some US states than it is maybe would be in some other settings.
Great. Thank you both so much for your time today. This was so engaging and so interesting. We are at time, so I want to just thank everyone who joined us today and for your questions. I'm sorry we didn't get to all of them, but we really appreciate your time and for caring about this issue and wanting to move forward in a way that is just and benefits as many people as we can. Thank you, everyone.